All right, welcome everyone. My name is Carol Boxta. I'm going to be today's moderator for this oral abstract session. We have 4 wonderful speakers lined up, and I'm excited to go ahead and introduce them. We will start off with Ms. Candida Halton. She is a healthcare strategist and communication specialist, the founder and director of Studio Health, which is an evidence-based consultory focused on improving health communications and how we talk about health. She is also a lecturer at the University of Westminster in London, UK. Ms. Ganira, you can go ahead and share your screen and get started.
Thank you. I hope you're seeing my title page. Great. Thank you very much for including us in the session today. As introduced, I'm Candida Halton from the UK, and I'm very pleased to present this on behalf of my co-authors of the abstract, Amy Sumner, Stacey Bailey, who were involved in the original impact research, Dr. Mary Jane Minkin, who is the host of the podcast that we're going to be talking about today, a colleague, Helen Bader, from the organisation Healthy Women, and also Sharon Mallon, who is from the sponsor of the podcast and the study itself, which is Pfizer Inc. So today I'm going to tell you a little bit about a study that we conducted exploring qualitatively the impact of a podcast designed to improve understanding and communication of menopause-related health information. I may be speaking to a menopause literate audience today, but perhaps just to cover a couple of salient facts about menopause. Obviously, all women go through menopause if they live to that point in their lives. And so this is a very significant milestone event for women. And menopause technically is defined as a year after the final menstrual period. But in fact, we know that a lot of the terminology around menopause is quite poorly understood, and that there are quite a range of symptoms. And this means that the understanding of menopause is perhaps not as good as it could be in the population of midlife women. And unfortunately, this lack of knowledge is also matched by a lack of reliable health information in this area. The study itself that I'm presenting to you today was conducted in the mid to late 2020. And so at this stage, I'm showing you some of the data on podcasts at that time, because we were interested to see if podcasts would provide an opportunity to improve communication of menopause. And back in 2020, we were starting to see this real engagement with podcasts as an information channel, specifically around healthcare information as well. And I guess in the intervening years, we've seen, particularly with COVID, actually, that there's been quite an uptake in podcast use more generally. There's 2 pieces of context I wanted to share before I come on to the study results themselves. The first is a much more recent survey from Healthy Women, the organisation from one of our authors, Helen Bader. And much more recently, they conducted, this was not a peer-reviewed piece of work, but they conducted a survey amongst their constituency, which is in essence the group of women that we would be talking about from a menopause and communication perspective. And it was really interesting to see these insights around the use of podcasts in this target audience. And this wasn't available at the time that we designed the original study. But we could see here that information in podcasts amongst this group was actually rated as more understandable and more actionable. And we found that these data were interesting, complementary data to the original impact study. And as you can see, participants who listened to the podcast reported higher levels of health activation, and that women were interested in using podcasts as a mechanism for learning more about women's health, and specifically menopause. So I thought it was just interesting to share some more recent data very specifically amongst that constituency. I think it's also helpful just to give you a sense of the podcast itself. It's publicly available. You can find it on all of the podcast platforms. We've just recently, the podcast itself has reached over 100,000 downloads. The structure of the podcast, the format of it is perhaps of what is particular interest here, in that it uses first-hand accounts from real women, very loosely edited. So it very much uses the storytelling approach to sharing health information. And Dr. Mary Jane Minkin, one of our co-authors on this abstract, on this presentation today, interjects with credible health information just to provide a little bit of context to the listener. But this is very much focused on first-person perspective storytelling as a way of engaging the audience. And so we were able to see from the work that we did, that I'm going to present to you, that we can see this connection with Fisher's narrative theory, with this idea that storytelling is a great way that adds credibility and authenticity to the health messages. So I hope that provides a little bit of background for the study itself, some interesting, perhaps a little bit fresher data around the use of podcasts as a mechanism for health information, and then just to cite you a little bit into the podcast itself. It's currently on the 3rd season. This particular study was conducted with the episodes contained in the 1st season. So here I'm sharing with you the aims and methods of the central impact study itself. And you can see that what we were aiming to do was to understand the impact of the podcast on women's menopause-related knowledge, their understanding, but also their communication practices. And now it's a cross-sectional qualitative study, so we're not able to robustly know what happened afterwards, but we were looking here for intentions, potentially, for a change, for a desire to communicate more openly about the menopause experience. The study recruited 30 US women. They were responding to an online advert, and they were then screened. And we then used the maximum variation sampling to try and get as great a diversity as possible. I've got a slide in a moment where you can have a look at our study population in a little bit more detail. The participants were offered recompense for their time, because we did require them to listen to all 5 episodes from season 1. And the research team used thematic analysis to analyse the interview and to look at the themes, which I'll be sharing with you. And so here I'm sharing with you the sample demographics. I think one of the sort of acknowledged limitations of the study it comes from the fact that it was online recruitment, from the fact that it was self-selection in that sense, that we were asking women to listen to the stories, to be able to participate. Nonetheless, the research team, I think we feel that we were able to draw quite a broad cohort for the study population, with, as you might expect, a sort of an age distribution around that menopause time. It's probably useful also just to call out here that this was quite a highly educated group as well, which I think is important when we think about the impact of the study itself. So I'm now going to share with you a slide on our key findings, the central themes that emerged from the thematic analysis. So I'm going to start at the top left of the screen here. This idea of this journey of knowledge gain, this was really interesting, this opportunity to learn from the other women sharing their stories, this sense that as they moved through the episodes, there was more to learn each time. There were these different individual experiences that collectively opened up this opportunity to learn more, and a sense of this unknown territory. There's this degree of stigma, I think, around menopause that was starting to be tackled by the stories that were shared. So linked to that is this sense of openness and authenticity, which is, of course, central to this idea of storytelling, that the strength of the stories themselves, this idea of sharing testimony, of sharing these personal experiences, and the fact that the voices themselves were of the women themselves, that there was quite light touch in the editing in terms of making sure it wasn't so crisp as to take some of the personality out of the voices themselves. And so we were able to see that there was this sense of community that starts to emerge from listening to the podcast itself. And there were some wonderful quotes from some of the participants about this sense of feeling less alone, which was a very striking finding for us. But we would also acknowledge the lack of representation that also came through. In season 1, we only had 5 stories to share. That is a limited experience of menopause itself. But overall, there was this opportunity to reframe menopause in a more positive way, opening up conversations, finding the sense of optimism and solidarity, and prioritizing self-care. So I'm just going to share with you the conclusions and the implications. We're coming just up to time, I think, Carol, aren't we? So we were proud that this study really was the first to explore the impact and mechanisms combining menopause education and podcast itself. As you've seen from those themes, we were able to identify that women did feel empowered to make change in their lives, and this sense of the authentic and relatable experiences through storytelling was seen to be significant for that. But we acknowledge that more diverse stories need to be included. For those of you that are interested in reading a little bit more about the study, we're pleased to have 2 publications. As you can see, one more targeted towards the menopause community, and then a recent publication in patient education and counselling. I'd also like to thank very much our participants and our researchers for the main study. And I think I also need to say thank you to the women who shared their stories on the podcast. Thank you.
All right, thank you. If anyone is interested or has any questions, you are more than welcome to put it on the questions and answers, or also include it in the chat, and we will go ahead and unmute you to let you speak.
I want to just mention, I don't know if people had heard, but one of the speakers in this panel was not able to come, which means that we actually have a little more time than typical for questions. And so maybe if I could start off asking you what you would like to do next with this work. And I have, there's a whole bunch of possibilities. So let's just give you the chance first to go at that. Yeah.
I think it's interesting for us to further explore what podcasts might offer amongst a broader population, and to look at again targeting. I think one of the things that was successful here was the care with which the content and the audience was targeted and the format that was used. And I think it's important to bear that in mind, that it's not podcasts per se, it's the channel plus the evidence base for the mechanism plus the audience. And I think that is really an area that we could explore further.
Yeah, absolutely. But one thing, you pointed this out, but one thing that would be fantastic is really to have people with less education, less social capital in other senses as well. I've just seen a ton of projects that would love to get at health literacy issues, but end up not really having, a spectrum of educational empowerment in the project, so like this could have, I think that's definitely one, awesome way. You pointed out yourself, but it's not like a surprise that this topic would come up.
No, it was definitely a limitation of the study, and a limitation of the recruitment mechanism as well.
Yeah, another direction to go really, and I think would be just fantastic, is is different cultural representation. So in some cultural, in some parts of the world, this is actually a more dangerous topic than in other places. There's shame and stigma associated in some societies with the end of fertility. Even if it's obvious to some, it's kind of a secret to others. And I've had patients where this was a massive, devastating blow, that this would be, and it had to be a secret, that this was what's happening in their life. I've also had patients where interpreters have told me, this is going to be a big deal. This is going to be a long conversation. There's no word for menopause in this language, so it's actually,
I mean, the whole question of language and actual vocabulary for women to describe stages of life, and particularly those, around reproduction and their bodies is one. I would add, so you're absolutely right, Michael, of course, there are cultures where there is greater stigmatization of that stage of life. There are cultures where it is celebrated as well.
Absolutely. Yeah.
That is very interesting. And in fact, one of the women who shares a story on season 1 talks much more about that. And there is a great deal of interest in people have encapsulated it differently, but this sense that once women are done with the reproductive role, there is this opportunity for wisdom and leadership within their community. So I hear you, but I want to add that as the counterpoint.
No, I absolutely. I certainly didn't mean to stigmatize or problematize for people that's not there at all. But just one more thing on this point, and then Elena has her hand up too, which is fantastic. I've learned from interpreters a lot, and they're basically cultural brokers as well, or cultural advocates, and it's just fantastic. But one time I was meeting with an interpreter with a patient, and then all of a sudden I realized that this patient had never known a woman who had lived long enough to plausibly be in menopause, other than malnutrition. And so actually, there's so much to deal with. Anyway, please, Elena. Yeah.
Oh, Elena, may I just say one very quick? I think there's also something interesting from a cultural perspective with the storytelling as well, and how open and honest those stories can be. And in fact, although it's not included in this study, there were, I think, 4 additional menopause unmuted programs that were created, one in Chile, one in Israel, and one in, I'm going to say it was Denmark. And it was extremely striking, the types of story and information that women were sharing in the different countries. Now, that's out of scope of the data that we have to present today, so it's only anecdotal, but it's really interesting, the honesty about the sexual symptoms of menopause, for example, the role of mothers and daughters, and so on. Sorry, Elena.
Yeah, I think I'd love to continue this conversation over, a glass of wine, in an extended period, but for the purposes of remote and all this, something else that would be additional to think about that you don't often think about in menopause is hearing the voices of the partners. And because it impacts them as well. And, and again, that also changes with different cultures and perhaps, a variety of other factors, financial, et cetera. But, if you're looking for sort of extending this and being inclusive and inclusive in dialogue, as well as the individuals involved, it's something to think about, for down the line. And it would resonate with so many people, and storytelling, I think we can do much more with storytelling, and it's not cultural specific, and I think we do it a lot more than we're aware of. We all tell stories, and we all communicate that way. We just don't label it that way. And so I see that Helen is on here in terms of podcasting. That's certainly, the way to communicate through different mediums and labeling of that. But thank you for this. It's really interesting.
I think, and thank you, Helen, for your comment. I think there's also something very personal about audio in comparison to video that suits very well for some of these more personal topics as well. When people are talking about painful sex or low sex drive, or topics that maybe are a little bit more challenging to kind of consume in a public sort of area. And this is one of the really interesting things about podcasts, right? They're so private in a way that other media are not. Yes, and exactly, because we're busy women in midlife, right? Like, none of us has only got one thing going on. So this is very good. We can listen to the podcast, and again, anecdotal, we can listen to the podcast while doing the 30 million other things that midlife women are achieving.
Well, great presentation, Candida. And as Kamara said, women helping women on these sensitive topics. It's a really good discussion, especially not only for the audience, but even also for providers to then understand what their patients' thoughts are, what they do and don't do. I actually had an opportunity to listen to one of the episodes, and the dialogue between a professional and then just the patients were really informational, like even for myself. And it was a really lovely podcast that
I'm very touched, Carol. Take your moderation role very seriously. I'm just going to post my email address in the chat, because unfortunately I'm not able to stay for the full session, but it is so exciting to talk about this project with this group of like-minded people, and I would be thrilled, offline, to pick up any questions, to carry on the conversation. And I really appreciate the contributions to help us think about how to take this further.
And with that, we will continue with our speakers. Again, if you have any questions, please feel free to put them in the chat or in the Q&A. Once the speaker is complete, is done with their presentation, I will go ahead and switch over to them. And next up, we have Dr. Elena Carbone. She has over 25 years of experience in health education, health literacy, and nutrition communication. And her research engages multi-ethnic communities with low health literacy skills and integrates behavioral interventions to promote health and prevent chronic disease complications. She's a professor of nutrition and associate dean for curriculum and academic oversight in the Honors College of the University of Massachusetts, Amherst. She is also a founding director of the Community Engagement Research Program at UMass, and has served as the PI for numerous foundation and federally funded community-based research studies. Without further ado, you can go ahead and share your screen. Please let me know if you need me to share them as well.
Thank you. Let's see. Oh, no, I think you're going to have to do the slides.
No worries.
For some reason, we're running into technological issues here. So thank you. All right, well, this is a very different kind of presentation for me, and it's been sort of a fun activity. I just wanted to share with you a journey that we've taken at the International Health Literacy Association in the development of a global vision document entitled Health Literacy for All. And for those of you who may not be familiar, ILA, or the International Health Literacy Association, is a non-governmental, nonprofit, member-based organization. It's got close to 1,800 members from 90 different countries. And its aim is to create health literacy for all and to work with others to do that. Okay, next slide, please. So in keeping with this, at our first Global Health Literacy Summit in October of 2021, that some of you may have attended, we asked members to work with us to co-create the ILA vision for health literacy for all. Next slide. And we did this by developing a brief, open-ended online survey that was available to all ILA members during the summit and then throughout the month of October. And we focused on some just very basic questions that asked what health literacy for all might look like, how it might be achieved, etc. We then downloaded the data into Excel, coded it, and identified emergent themes. Next slide, please. So I briefly want to present the results of that first round of data collection, but then more interestingly, present that within the constructs of a framework that we found for successful research partnerships in global health. So not specifically targeted to this, but was really interesting to look at the data from that perspective. So we'll just start with the demographic data from this first round of collection. We had 6 global regions represented and a cross-section of professions. Next slide. And I just wanted to take a quick look at each one of the questions that we asked. And just to let you know, anything that is in italics are direct quotes from our respondents, because these were all, as I said, open-ended questions. So we asked, what should be done to improve health literacy for all? And what we found is what you might expect, making sure that there's adequate training and education at all levels. And that aspect of all levels, I did want to emphasize because that is a recurrent theme through the life course. And making sure that there's access to these clear pieces of information and education. And then pulling back a little bit for the broader perspective, changing existing health structures and systems as well as policies, and overall increasing awareness of the need for health literacy and the importance of it. And then underlying all of this is to really prioritize equity and inclusion. And as this quote so eloquently says, integrating equity as an inherent part of all health literacy work. I think that really says it all. Next slide, please. So when we asked where can health literacy for all be improved, the answer is everywhere. It should come as no surprise. Every public health interface in developing and developed countries and through the media. And in essence, really embracing that concept of meeting people where they're at. Next slide. When can health literacy for all be improved? Well, as early as possible and throughout that whole life course approach. And as these quotes are saying, compassion and awareness, yesterday, today, and tomorrow, because clearly now is the time for action. Next slide. So who should improve health literacy for all? Everyone, it's a shared responsibility, but there was a specific call out of institutions saying that they're the ones who should drive educational and health equity and training and the training structure and support the processes to ensure, again, equitable outcomes. Next slide. In response to the question that we asked about why should we improve health literacy for all, we know from the data that improved health literacy corresponds with improved health outcomes and quality of life, increased knowledge. It makes public health campaigns more effective, and it also overcomes many of the inequities and increases empowerment. And besides that, or in addition to that, everyone does have the right to make informed decisions about their health. Health literacy is an instrument of change, and we all know it is the right thing to do. Next slide. So how can we do this? Well, by making this a multifaceted approach and making it every day, really focusing on actionable items and making the communications open and ongoing. And when we say multifaceted, everything from existing policies and laws to funding mechanisms, what training and accreditation options there are available, what kind of advocacy efforts are presented, and really looking at an entire fundamental shift of societal and cultural, actually that should be norms. And the idea of bringing diverse constituents together, really people that may not always come to the table and talk about this, but to be part of the conversation and take the long-term view. And then again, really improving health literacy among the disenfranchised and marginalized populations. And then finally, next slide, we asked how ILA specifically can improve health literacy. So specifically looking at our membership and the advocacy that's offered, the types of training and professional development we have, serving as one of the many open forums like this one for discussions and innovative ideas and best practices, The support for researchers and practitioners, again, through the early stage to more senior level, investing in equity and inclusion, and lobbying. So ILA can certainly be one of the points of contact for health literacy information, research, funding, and training. Okay, so next slide. I want to turn attention to this framework. Now it was, as I mentioned before, developed for global research partnerships, but it was really useful and interesting to use it as a way to examine our data. So I just wanted to start with the 7 core concepts and then talk a little bit about the attributes that correspond to each concept. So starting with focus, making sure that the focus is clear, that it's shared and it's a common goal. And in addition to cultural and societal norms, trust is very key in establishing the values. In terms of equity, the need for inclusion, sharing of resources, and respecting different capacities at different levels and stages that one might want to contribute to this global vision. In terms of benefits, making sure they're reciprocal and mutually beneficial to all. Communication should be open, honest, and effective. Anyone in a leadership position should make it clear the delegation of those roles and have accountability. And finally, should any questions or differences occur, making sure there's mediation is needed and conflict resolution. Next slide, please. So this slide shows the broader categories that correspond to those core concepts. So the relational, partnership, and operational. And applying those core concepts to the formation of the desired outcomes of increased capacity, influencing practice, and enacting change increases the probability of achieving the goal of a successful partnership. In this case, the successful partnership to develop this global vision. And I wanted to point out, if you can see, again, I'm using my pointer, but you probably can't see my pointer. Down below, you'll see that it, thank you, Carol, that it's an ongoing process. It's not a linear process. So the monitoring and evaluation is something that continually should be revisited. Next slide, please. So looking at those 3 major categories of relational, partnership, and operational, when we looked at our own results, we examined them in relation to these 3 broader categories. Overall, the data from the literature suggests that global health partnerships, whether they're research oriented or in this case, developing the vision, are dependent upon successful relationships as much as, if not more than, successful operations. So the 2 are interdependent. So when we look more specifically at relational, making sure that the area of focus that we're prioritizing aligns with partnership opportunities and making sure that there is a clear and mutual understanding of what that focus is. The fact that everyone has the right to make informed health decisions is the value that is fundamental to even moving forward with this whole initiative. Making sure that equity is an inherent part of all the health literacy work that we do, clarifying the benefits and managing expectations, particularly between early and mid-career professionals, making sure communications are ongoing and clear. Next slide, please. And then in terms of the leadership, making ILA one of the partners, one of the organizations that can be sort of a point of contact. We have our own bylaws that are established for any resolution of conflicts. And the other thing to mention is funding mechanisms to keep this work going. In addition to sharing this type of vision with other organizations that are prioritizing health literacy, working with others to develop creative funding mechanisms to keep this momentum going. Next slide. So some lessons learned and practical applications. We should acknowledge and actually embrace the different stages in the development process of this vision. Addressing limitations and issues of concern that come up as soon as possible, and that feeds into this ongoing monitoring and evaluation. Being flexible, equitable, and inclusive are critical to every stage of this process. Next slide. So the next steps that we would like to think about for Vision for All is to inform policy and advocacy efforts. And it will also specifically work to inform our interest groups, maintaining fluid and transparent communications with our membership and with others, exploring creative partnerships, expanding our membership, and ongoing data collection. Next slide. And in the spirit of ongoing data collection and access, what I wanted to do is, I don't know if I can try to share with everybody.
You can also put it on the chat and then I can share it with everyone.
Okay, I think I'm able to do this. Okay, next slide. So if you're interested, we'd love to hear people's input. And I wanted to acknowledge the International Health Literacy Association members, and especially the collaborators on this abstract, Dr. Orkin, the Vice President, and Dr. Sorensen, the Vice President and President. Next slide. These are my references really quickly, and I thank you.
All right. Thank you for your presentation. Let me look quickly at the Q&A.
So I see we have a question. Anyone interested in doing in Africa? We absolutely have interest in, if we want to hear from folks. And I know that there are some interest groups that are doing work in Africa. We'd certainly love to hear from everyone. This is an inclusive, ongoing process. So if you're interested, I'm more than happy to, and in fact, I'm going to put my email address in the chat.
And the link has been also included to the chat in case you want to participate in the survey.
Okay, good. Well, Fletcher, I would be happy to chat with you and see what kind of dialogue we can engage in. And this, I have to say, this was, I usually present, very traditionally on, what the research has been, what the implications, the method and all of that, but it was kind of fun to take a step away and look at the process of this, because it is such a global organization, and we really need to have voices across different cultures if we're going to have this kind of vision for health literacy for all. It really does make sense that we are as inclusive as possible. So I must say, it was enjoyable.
And just a quick question, do you guys plan on developing like a framework to share with everyone once all the data has been collected?
Yeah, I'm not sure we'll ever say that it's all been collected, but I would, I'd like to think, we're going to be, the process is to continuously develop this, expand this, and then see what we can do, as you said, as a framework, as guidelines, recommendations, thought processes. I think it's also an evolving topic. What does health literacy for all look like now compared to what it might have looked like, pre-pandemic? We continuously need to revisit it and, see that this is the beginning of, not the end of, an ongoing conversation, an exploration. Let's call it an exploration journey, maybe.
All right, let me see. As of right now, we do not have any other questions open. Feel free to continue to add them
Okay,
in the
thank
chat
you.
or Q&A. If there's any other kind of highlights you would like to discuss, you're more than welcome to, Dr. Elena.
No, that's really all that I had to share. If, as I said, if anyone wants to engage in conversations, we've got, I know Sabrina was here, so we've got other folks from ILA, and we're happy to chat.
Yeah, I just want to add that I still remember about 6 years ago when I was still a doctoral student, I attended the HARC conference and knew about AILA, and I became a member of AILA. And it's amazing to see, over the 6 years, how AILA has grown, all the progress, the things you guys are doing. That's amazing.
Oh, well, thank you for that. And one of the things that we really embrace is, early and mid-career professionals and getting them involved. They are the next generation of the spokespeople for this. So thank you for coming on the journey with us. That's actually fun to hear. Okay, thank you.
Thank you. And we will continue on now with Dr. Shuiwei Chen. She is an assistant professor of health education and promotion at Oklahoma State University. Previously, she obtained her PhD in health education from Texas A&M University as a distinguished honor graduate, which was followed by a postdoctoral fellowship within the School of Public Health and Health Professions at the University of Buffalo. Her research focuses on improving health literacy and health communications to reduce health disparities among underrepresented groups, including immigrants with limited English proficiency, rural residents, and racial and ethnic minorities such as Native Americans, African Americans, and Latinos. All right. Dr. Shuiwei Chen, you are more than welcome to go ahead and share your screen. And again, any questions, you can put them in the Q&A or in the chat.
Thanks for your introduction, Carol. Right, and thanks for the opportunity to present our study at this conference. And Dr. Carrie Winterwood is my co-author on this study. Okay. We used Dorm's and colleagues' definition for mental health literacy, which refers to knowledge and beliefs about mental disorders with aid in their recognition, management, or prevention. And previous research documented that American Indians and Alaska Natives had a high rate of experiencing poor mental health, and they also had lower mental health literacy confidence than other racial ethnic groups in the US. So the purpose of our study is to examine how mental health literacy is associated with access to mental health professionals, use of mental health professionals, and trust in mental health professionals among AIN population. We conducted data collection in February 2022. Our participation criteria included being 18 years or older, self-identified as AIAN, and physically located in the US. We applied snowball sampling strategy by sending out recruitment flyers to colleagues who conduct research and or practice among AIN communities and professional student organizations such as State Tribal Engagement Partners, College American Indian Student Association, and Institute for Healthcare Advancement Health Literacy Solutions Center. So those professionals further disseminate that recruitment information to their social or professional network. And we included an anonymous link and a QR code to our online Qualtrics survey in our recruitment flyer. We adapt June and colleagues' multi-component health literacy measure. So this measure assess individuals' mental health literacy in 3 domains: knowledge-oriented, beliefs-oriented, and resource-oriented. The knowledge-oriented item asks participants if they agree with the statement such as counseling/therapy is helpful for people with mental health needs. So participants can choose from yes, no, or don't know. And the beliefs and the resource-oriented items ask participants how much they agree with the statement on a 5-point Likert scale from strongly agree to strongly disagree. For example, a highly spiritual religious person does not develop mental health concerns, and I know where to go to receive mental health services. And Corbin's alpha coefficients indicate good internal consistency of the measure. So that's 0.83 for knowledge-oriented scores, 0.90 for belief-oriented scores, and 0.73 for resource-oriented scores. And the overall Cronbach's alpha is 0.91. And we also collected participants' social demographic information, such as age, gender, and education attainment. And mental health care access was measured by asking whether they had at least one mental health care provider they usually go to when they were not feeling well and needed mental health care. We also measured their frequency of using and the level of trust in mental health providers and the mental health specialists for health information in general, as well as the frequency of using and the level of trust in mental health providers and the mental health specialists as sources for COVID-19 information in particular. Then we asked participants, how much trust do you have for your mental health providers and the mental health specialists to measure their level of trust? We also asked participants, how satisfied are you with the service you received from your mental health providers and mental health specialist to measure the level of satisfaction with the service they received. And for the data analysis, we perform multiple linear regression models to examining the relationship between mental health literacy and one, social demographic characteristics like age, gender, and education, and two, mental health care access. And number three is the frequency of using and the level of trust in mental health providers and the mental health specialists as sources for health information in general. And four, that's the frequency of using and the level of trust in mental health providers and mental health specialists as sources for COVID-19 information in particular. And number five is the level of trust in mental health providers and specialists. And the last one is the level of satisfaction with the service they received from their mental health providers and the specialists. So our final sample size for data analysis included 563 participants. And here's their demographic information. We had about 62% male participants and 38 female participants. Their age ranged from 20 to 66, with the mean of 33.8 and standard deviation of 5.45. And most of them had some college education or graduate from college. We found that females had lower mental health literacy than males. Higher age and higher education were associated with better mental health. And when holding age, gender, and education constant, those not having at least one mental health care provider they usually go to were more likely to have poor mental health literacy. And further, when holding age, gender, education, and the mental health care access constant, poor mental health literacy was associated with being less likely to trust mental health specialists for COVID-19 information and being less likely to trust mental health providers and mental health specialists, and also having lower satisfaction with the service they received from their mental health providers and mental health specialists. in previous study, females generally had higher mental health literacy compared to male, and older age was associated with poor mental health literacy. However, we find a different story. So in our study, we found that AIN females had lower mental health literacy compared to males, and higher age was associated with better mental health literacy among AIN people in this sample. So we think the literature might help explain why the findings among AIN population is unique. So the first one is AIN women are particularly impacted by poor mental health. And second, AIN teenagers and young adults are disproportionately affected by stress, depression, and suicide. And we also found that AIN people's mental health literacy was positively associated with their access to mental health professionals, as well as their trust in and the satisfaction with mental health professionals. So based on the results of our findings, mental health literacy among AIN people may be enhanced if they have better access to mental health providers, as well as they have trust in and are satisfied with the mental health service they received from their mental health providers. And that's the references. And here's my contact information. Thanks for the opportunity presenting this study again.
And feel free to add in your information if you would like to on the chat in case anyone would like to get in contact with you.
Sure.
I have a question. If you could go back to your discussion items, I'm not sure I understood. Maybe if you could explain to me again or elaborate. There was a connection that you were describing between the mental health literacy and building trust. I'm not sure I understood what you were describing there.
So yeah, we found the association among lower mental health literacy was associated with lower trust in mental health providers and mental health specialists. So I think working on building the trust between the patients and their mental health care providers maybe can be a potential strategy to enhance their mental health literacy.
And what are you thinking of doing next with this work?
Yeah, so in the state of Oklahoma, we have more than 30 Native American tribes living in Oklahoma, and we're collaborating with them to try to address the mental health issue. And the trust issue is a key component in terms of unique among AIN population. So I think there's more work need to be done trying to increase their trust among just general healthcare providers. So we need to provide more culturally appropriate training and service, especially among healthcare providers, including mental health care providers, so they can better communicate and educate racial, ethnic minority populations, such as AIN communities.
Yeah, this is a huge challenge and topic. I mean, one of the things people will say also is, of course, that we have to diversify the healthcare workforce. And so maybe you know already, but you know, do you have a sense of what portion of the mental health workforce are members of are AIAN themselves?
Oh, I do have the exact percent number, but I know this is a huge problem, especially in rural areas where we see shortage of healthcare providers. And also that applies to AIN community as well. So if we have, those healthcare providers are self-identify as a community member, then they will receive more trust among the community members, for sure.
Well, possibly. I mean, that's one of the main hopes. Yeah. And there's a comment. I think Elena, maybe you turned on your camera, so maybe you were going to say something. No. Oh, there's a comment here from Radhika.
Yes, and it talks about her comment talks about the mental health and the climate change and how this exacerbates many social, environmental, and economic risk factors and problems for mental health. If we're talking about the same comment, if you have anything to speak about that regard.
Oh no, that was Sabrina. Sure. I don't know if Sabrina wants to. If you raise your hand, you can speak as well. You can be unmuted. The next comment there also, Carol.
Yes, about historical trauma and how it plays a major role in trust issues and healthcare in general.
Yes, absolutely.
And I'm wondering if maybe having provider recommendations to see mental health professionals might help also with some of this, easing them into the AI community, into speaking with someone. But I did have a question about, I don't know if you specifically stated that a recruitment that they could choose for to be anonymous or to put their information in there. Was this an option, and did it cause any changes for recruitment? Did you see that it kind of helped out recruitment, or how do you feel?
For the recruitment part, no, we didn't ask them to put in their information. It's all completely anonymous.
Oh, okay, that's good to hear.
Just another, this is another project where like a lot of the respondents were very educated. You had a very high level of education.
Right.
And it is what it is, but it's worthwhile thinking, for everybody to think about how to make sure that the enrollment methods will end up with a representative sample so that you end up having enough diversity so that you can, because when you're thinking about something like health literacy research, even before you measure anyone's health literacy about any domain, if you have a very highly educated sample, then you are cutting yourself short for the possibility of being able to see, some of these phenomena very well. So we have, you can be unmuted if you raise your hand. I don't know if Radhika, you wanted to describe this, and also Sabrina, you mentioned this other resource that you wanted to talk about with respect to mental health and climate change. Go ahead, Carol.
Yeah, feel free to, okay, let me go ahead and.
Hi there. All right.
We can hear you, yes.
All right. So I just wanted to, this is a great topic, and thank you so much for this, strong research. So I just shared a resource that I just recently found on mental health and climate change, because it's such a big issue. And I was wondering if in the community that you worked in, issues around climate change were impacting, or people were concerned about that in terms of a mental a mental health issue. Perhaps the speaker could comment on that.
I mean, maybe not particular to climate change, but we definitely see there's a higher rate of mental health issue during the COVID-19 pandemic.
Mhm.
Yeah.
Thank you. The other thing I just also wanted to just add, given the opportunity, that adult education programs are a great place for, because I find this, to engage more a diverse educational background in our research. Recently did some work and worked with our stakeholder expert panel through the university, and still got a very highly educated group, even though this was meant to be kind of community representatives. So I guess I really, and others perhaps, experience needing to go and work with community-based organizations, and especially adult literacy and English language classes in the community to engage, a broader number of people with diverse educational backgrounds in our research.
Yeah, it's a challenge for a lot of projects. I could just say that I've gotten many submissions to the journal that like want to look at health literacy issues, but then like the sample is so educated that it's really hard for the authors to really do the analyses even. You have enough of a sample, Zhuwei, that you were able to do the analysis, but you could imagine that if it really just depends on the methods that are used for engaging with potential participants, and online methods just often come short, just because who's using surveys online and how, that kind of a thing. There are companies that say they can augment your online sample with people with less education, but you just have to be very careful with that, that approach.
Right. I mean, that's definitely is a limitation of using online survey.
Yeah. You brought up the issue of COVID-19, and there was actually exactly what this comment was from Veronica as well. I don't know if you've, clearly stress has been going up everywhere. But and then also that changed how people had access to healthcare, and but in bizarre ways now we have more telehealth, and maybe especially in rural environments where travel is so complicated and difficult for people, telemedicine actually maybe increased access. I don't know, did you have any phenomena like this?
Yeah, I think the telemedicine is definitely a strategy, can lower the barriers of access. But in rural community, we also have the lack of access to internet. So those individuals, still cannot take advantage of using telemedicine. So for another possible solution, maybe, using mobile health clinic unit to bring the service to the community who are lack of transportation. So I know the state of Oklahoma, the health department, they're doing, bring the mobile van, the unit to the community so they can have access to those basic healthcare needs.
Dr. Elena, you have a question?
Yeah, in follow-up to that, I'm curious whether I love the idea of the van, because that has worked so well to give rural communities access to mammography and other screenings and things like that. I guess thinking about whether there's still the social stigma of, seeking, even having mental health services come to you, there's still a stigma about actually making them part of your life and accepting them. So I think part of it is that general idea, but also getting into, you've got a lot of cultural different groups to work with here, and their frame of reference and their norms and their values. And so, you know, it's not as easy as telehealth. It's not as easy as the mobile vans. It's all of that, plus it's more complicated because of the subject matter. So I think, you know, studies like this are really building a strong foundation for that. And, you know, we should celebrate and award more research in this area, because I think, you know, it has gotten worse, and in some ways, you know, the COVID has opened up new avenues for some people, but the distinction between those who have and those who have not got access to these services is still there, and it's growing. So thank you for this work, because I think it's really interesting.
Thank you, Elena. I will put my contact information in the chat as well.
My video keeps going in and out, so I'm going to.
Thank you, Dr. Chen. And that is actually all we have for the Q&A as well as the chat. If anyone would like to put in any last minute questions, feel free to.
No, so we did have you know, one speaker in this session who wasn't able to come, so we're going to end now. There's the next session actually doesn't start till the half hour, so till 4:30 Eastern time. Please rejoin us at that point. Thank you for everyone who participated in this session, and I hope to see you in one of the two rooms at 4:30 Eastern. All right, thank you.
Thank you, everyone.
Thank you.